to this webinar. My name is Julie Bartel, and I am a clinical pharmacotherapist at SSM Monroe Clinic, and I'm going to be talking today about billing for pharmacist-provided services. We're going to be talking about various different kinds of billing methods, and I hope that everybody finds this helpful. It has certainly been a long road to learn all about these different billing methods. Just to give you a little bit of background, I have a clinical practice at Monroe Clinic, which I started about a decade ago. And believe me, billing methods are very, very confusing, particularly in the clinic setting, which is what we're going to focus on today. A lot of trial and error to figure out what works, and more different ways to bill have come into light over the past years. And so hopefully, after this webinar, you'll have a good idea of different types of billing that you can use in your clinics. I don't have anything to disclose. As far as our learning objectives today, I would like everybody to understand different common billing methods available for pharmacists, and then importantly, define different requirements for direct and general supervision and really understand what that means and when you can use each of those different methods or requirements. You can, hopefully you'll be able to choose appropriate billing methods for various practice settings, and then identify different pros and cons used with different billing methods. We're going to be talking briefly about many different things, as you can see from this outline, but we'll start with just a general overview and cover some important definitions to make sure everybody's on the same page. And then we're going to go and parry through all of these different billing methods, just hitting briefly on the last couple. All right, so as I mentioned, we'll start with a general overview and some general terminology just to make sure everybody is starting from the same place. So first, the definition of what a payer is. So a payer is an entity that is distinct from the patient that is responsible for the payment or reimbursement of the cost of health services provided. So as an example, we've got our Medicare as a payer or Medicaid as a state payer. We have private insurances from the private sector, so people can go out and pay to belong to a private insurance. That would be responsible for paying for at least part of their healthcare services. And then we have different government payers, such as the VA or Indian Health Services, which we're not going to really touch on at all today. So aside from our payers, we also have benefits, and that, of course, is what the patient receives. And so we have medical benefits, and a classic example of that would be Medicare Part B, which pays for the health services in the clinic if a patient has Medicare. And then we have our drug benefits, and as an example of that, I'm sure everybody is familiar with Medicare Part D, and that would cover the drug costs of a plan. Very importantly, it's essential that we understand who Medicare recognizes as official non-physician providers, and we'll refer to these as MPPs. And you can see that Medicare does recognize a variety of different healthcare providers, but unfortunately, a pharmacist is not on that list. And that presents many challenges when we think about how we can bill for the services that we provide. It's very important to understand whether or not you are working in what we consider a hospital-based clinic or a physician-based clinic. And I'll use my institution, Monroe Clinic, as an example of kind of a classic hospital-based clinic. So, for example, in a hospital-based clinic, you are financially integrated between your hospital services and your clinic services. So, for example, at Monroe Clinic, we have a single CFO or Chief Financial Officer that's responsible for both the hospital and the clinic. We have one budget. All of our financial reports integrate the hospital side and the clinic side. And that's different from a physician-based clinic where those finances are kept separate. So typically they would have separate CFO and accounting staff for their clinic services, and that would be distinct from their hospital services. Even if it's the same system, those two finances are separate. and same thing with their budgeting, et cetera. Additionally, in a hospital-based clinic, we would have clinical integration, and that means we share between the hospital and the clinic services clinical oversight. So we have the same chief medical officer that oversees both the hospital services and the clinic services. We have integrated medical records. So, for example, if you use Epic, we share an Epic platform between the hospital and the clinic. And then those who have medical privileges or clinical privileges are shared between the hospital and the clinic as well. So there would just be one application for privileging. So, for example, you might have a cardiologist. They get hired to your organization. They apply for privileges, one application, and that would cover them both for their clinic services, and then they could jump over and see hospital patients and vice versa. Whereas in a physician-based clinic, all of those things are separated. So they would have separate clinical oversight on the hospital side and the clinic side. Typically, those medical records are not the same. And then clinical privileges, you might still have a cardiologist that works in the clinic and then, every half day or something shoots over to the hospital. But typically that would be two separate applications for privileges at both of those different organizations, or not organizations, but clinic versus hospital. Public awareness and advertising would be shared in a hospital-based clinic, so you are advertising yourself to the public as a single entity versus they would be separate identities in a physician-based clinic. And then importantly, or interestingly, I should say, in a hospital-based clinic, patients receive a single bill, and that bill represents everything from the professional services provided from your physician or MPP, et cetera, as well as any charges related to using the facility or the clinic or hospital. In a physician-based clinic, patients would receive two separate bills. One bill would represent the professional services, and then they would receive a second bill that represents the facilities portion of that bill. And we'll get a little bit more into what that means in a second. Okay, so I mentioned how it's important to understand the difference between direct supervision and general supervision. So with direct supervision, the physician or MPP must be in the same building or same office suite. So in other words, under the same roof as the pharmacist or other provider who is not recognized as a Medicare recognized provider. They need to be, the physician or supervising MPP must be under that same roof and readily available if needed. In general supervision, that requirement is relaxed. And so the pharmacist can actually deliver whatever service they're providing to the patient at a location remote from the physician or MPP. So you wouldn't have to be under the same roof in this case. The physician or MPP could be in a different building or a different location as long as they were readily obtainable by phone. Oftentimes, people get really confused with references on how we bill, and usually that's by CPT code. And CPT code is essentially just a fancy way of letting our payers know the complexity or the type of visit that we're providing to the patient. There are 5-digit codes, and they describe what medical procedures or services the provider provided to the patient. CPT codes are often used interchangeably with the term E&M codes, or evaluation and management codes. Essentially, for our purposes, they represent the same thing. They represent the professional services provided to a patient. Technically, or literally, an E&M code is actually a section of the CPT coding known as in Category 1. But for our purposes, a CPT code and an E&M code pretty much mean the same thing. Then we have our G codes, and essentially this is our fail-safe. G codes are used to describe any service or anything for which there isn't a CPT code to recognize it. So oftentimes we refer to facility fees as using G codes as an example. Okay, with that bit of an overview, let's go ahead and jump into our first type of billing, which is known as Incident to billing. Another way that we describe Incident to billing oftentimes is non-facility billing or professional fees. So this uses CPT codes because we are referring to professional fees. And the codes that are used to bill Incident to go from 99211 to 99215. And each one of those codes represents a different level of complexity, with 99211 being the most simple visit, all the way up to 99215, which represents a much more complex patient. The nice thing about Incident to codes is they can be used in both a hospital-based clinic and a physician-based clinic. So it doesn't matter what type of institution you work in, you can use these codes in either setting, and that makes sense because these are codes that are meant to reimburse or pay for those professional services provided by the physician. They do require that a patient have a relationship with the billing physician and some sort of documented treatment plan. So you can't just bill these willy-nilly. The patient actually has to have that relationship with the person who is providing the service, which makes sense. And there are different documentation requirements. So you need to have documentation of history, patient history, physical exam, and some sort of medical decision-making that has to correspond with the level that you're billing. You need to have all of the healthcare problems or the presenting problems, your counseling and your care coordination that you provided to the patient. And you also have to have some sort of evaluation or documentation of time that you spent with the patient. One caveat with Incident to billing is if that physician is not providing the service or the MPP, anybody else who is billing Incident to, it does require direct supervision to be able to do this. So you do have to have your supervising physician or MPP essentially under the same roof as you provide as a pharmacist providing this service. Incident to rules, essentially, and regulations are controlled by the Regional Medicare Administrative Contractor, or MAC. And they decide what professions, who's going to be covered and able to bill Incident to. And universally, they say that pharmacists are not recognized as a Medicare provider. And so we are restricted to only being able to bill at a 99211 level, which, as I mentioned, is the most simple level. So the 99211 visit is commonly referred to as a nurse-only visit. It represents only 5 minutes of time and no medical decision-making. So they're essentially saying, we're not really offering any professional services. It's the most basic visit that you could have. And it doesn't matter. You could spend 90 minutes with a new diabetic patient and educate them and change their medications and order labs and do all of those things. But if you're billing Incident to, you're restricted to being able to bill a 99211. Incident to billing must be billed under the Medicare Recognized Providers MPI, or National Provider Identification Number. So you're billing it Incident to your supervising physician, essentially, or their physician that referred you the patient. One more caveat with Incident to billing is that you cannot bill this code if the patient is seeing that same billing provider on the same day that you're providing the service. And that, makes sense from Medicare's standpoint because it would essentially be like double dipping. That physician is already billing an Incident to code, and so you can't bill another code under that same physician because Medicare would have to pay that twice. All right, let's look at reimbursement or payment from Incident to billing. So this is what the provider would be paid or reimbursed in the state of Wisconsin from 2018. So you can see that the payments range from about $21 for that most basic 99211 visit, all the way up to $141 for the more complex 99215 visits. And then there's a range in between. The MPPs, again, those non-physician providers that are recognized by Medicare currently, do get reimbursed at about 85% of what the physician would make. So you can see that because pharmacists are restricted to that 99211 level, we make about $20 per visit. Unfortunately, other payers typically follow whatever Medicare does, unless you are able and lucky enough to, contract with them for some other payment agreements. But in general, state Medicaid would follow these Medicare rules, as well as most commercial payers. Self-pay is a little bit different in that would be a decision that your local institution would make with regards to what they're going to charge patients for your services. Okay, that brings us to the next type of billing, which is facility fee billing. So as I mentioned earlier, facility fee billing is not meant to pay for professional services, and so therefore we use a G code, so it's GO433. What the facility pays for is, it covers the facility, the use of the facility by the patient. So it covers, the electricity and the computers and the water and the heat and all of that type of stuff. No professional services, though. We used to have categorized G codes representing different amounts of time that the patient utilized the resources. However, as of 2014, all visits, regardless of time, are now billed under that single G0433 billing code and reimbursed exactly the same, regardless of whether a patient is spending 5 minutes in your institution or clinic or 90 minutes. The biggest thing to remember about facility fee billing is that it is only applicable if you are practicing in a hospital-based clinic. So you cannot use these codes if you are in a physician-based clinic. The nice part, though, is that you do not need to be recognized as a Medicare Part B provider to charge a facility fee, again, because you're not literally charging for any professional services provided. Similar to Incident 2 billing, you cannot bill a facility fee if that patient is seeing the referring provider on the same day, because similar to Incident 2, that would be double dipping, because that referring provider is also going to be coding for a facility fee along with their Incident 2 fee. Facility fee billing does require direct supervision. So again, you do have to have that supervising physician under the same roof or in the same clinic building as you are providing the services. And facility fees are regulated by a different organization, the Hospital Outpatient Prospective Payment System, or HOPS, Ambulatory Payment Codes, or APC codes. So what does a facility fee pay? It's actually pretty good. So similar to Incident 2, we would bill facility fees under that Medicare recognized provider's MPI number, but the reimbursement or payment for this type of code is $124 per visit. So when you compare payment from a facility fee to an Incident 2 fee that a pharmacist can bill at 99211, the difference is about $100 per encounter. So that's a decent amount. Again, the caveat is you have to be in a hospital-based clinic in order to be able to use the facility fee billing model. Okay, the next type of visit we're going to talk about is the Medicare Annual Wellness Visit, referred to as a MAV. So the MAV visit is relatively new. It was effective or created in 2011 as part of the Affordable Care Act. And the goal of a MAV is really to promote health and encourage preventative services for our Medicare population. As part of that, when a patient has a MAV, you must provide that patient with a personal preventive health plan, which makes sense. So this is, screening for colonoscopies and are you safe at home? Do you need a mammography? All of those types of things, immunizations. The nice thing about MAVs is that they cost absolutely nothing to the patient. So there are zero out-of-pocket costs, which is distinct from any other kind of Medicare visit a patient may have. One thing to remember, though, and important when you're talking to patients about MOVs or during MOVs, is that anything that you order as a result from that MOV, so if you order that colonoscopy or you order those labs that that patient needs or any sort of procedure, et cetera, those are subjected to the copay, the patient's typical copay. So that part's not no cost to the patient, but the actual MOV visit is zero cost. A MOV visit is distinct from a routine physical, and in fact, they are often scheduled back to back. So, oftentimes, at least at my hospital or my clinic, a patient would arrive and they would have a MOV followed directly by a physical from their physician. And both of those visits are billable. And the nice thing about MOVs is that Medicare says that these can be provided by a physician or an MPP or and I quote, medical professional. However, they do include a pharmacist as a medical professional that is able to give a patient a MOV as long as they are working under direct supervision. So that's great, especially when you look at reimbursements from these MOV visits. For those of you who may not be familiar with what a MOV is or what that is, what's involved in a MOV, there are three different types of MOVs. There is an initial preventative physical exam, and that's often referred to as the Welcome to Medicare visit. This is a visit. It must be given to a patient within the first year of them qualifying for Medicare. And it has to be given by either a physician or MPP. So a pharmacist cannot give this Welcome to Medicare visit. However, both of the, or all of the visits after that, all of the MOVs after that that patient might receive can be given by a pharmacist. And that would include the first annual wellness visit, and that would be anytime after the initial 12 months of enrollment to Medicare, as well as subsequent annual wellness visits. And a patient would qualify for that every 12 months thereafter, after that first one. And both of those, as I mentioned, can be provided by a pharmacist. If you've never given a patient a MOV, this is a very brief overview of what's involved, but essentially you're acquiring a health history and you're looking for different health, or you're completing a health risk assessment. So looking for different risks that that patient may have. It might be tobacco use, or it might be obesity, or it might be a falls risk at home. You collect a current list of medical providers that the patient sees, get that medical and family history, you're screening for depression, and doing that functional ability and safety review. You're assessing vitals, you're doing a mini cog to test for dementia, and then you're counseling. So you must provide the patient with a written screening schedule of everything that they should have done, including immunizations, colonoscopies, etc. You need to provide a list of risk factors and interventions that are underway. So for an example, let's say you have an obese patient, you might recommend that they follow up with an obesity clinic. Or you have somebody who recently had a heart attack, maybe you recommend cardiac rehab, et cetera. Then you counsel them on that personal health advice, as I mentioned, related referrals. And then if the patient's interested and it's indicated, you can do some advanced care planning as well. So I sort of alluded to the fact that MOVs reimburse pretty well. Similar to the other visit types that we've seen, you would bill these under the MPI of that physician or MPP. And as I also alluded to, the nice thing about these visits is they can be billed even if the patient has another visit type on the same day by that referring or supervising physician or MPP. There are two different G codes that are used for the MOV billing. That initial MOV is a G0438, and again, that's that first visit after 12 months of Medicare enrollment, and that reimburses at $168 in 2018. And then G0439 is every visit thereafter, again, once a year, and that reimburses at $114. So pretty decent reimbursement rates. The next type of visit we'll talk about is the chronic care management or CCM visits. So CCM visits was created by Medicare to attempt to recognize, pay for some of the non-face-to-face management for our patients that have chronic health conditions. So this is, to my knowledge, the only way that we can currently get reimbursed for any sort of, telephone management of chronic conditions. In order to qualify, patients must qualify for Medicare, of course, and then they need to have at least 2 or more chronic health conditions that are chronic, so expected to last more than 12 months or until their death. I have a list here of what they state as examples of chronic conditions. However, do note that this is not an exclusive list. You could have another chronic condition that's not on this list that you could argue would qualify for CCM management. There are some aspects of CCM that doesn't make it completely user-friendly, I would say. For example, patients, they must give either verbal or written consent to enroll for the CCM program, and that enrollment can take place either during a routine E&M office visit with their physician or MPP, or it could take place during a MOV. Patients who are in long-term care facilities or inpatient facilities do not qualify for CCM. The initial assessment must be done by a physician or MPP for that CCM patient. And that physician or MPP has to document a comprehensive care plan, in other words, goals for the patient. However, after that initial assessment and enrollment of the patient in CCM, all of the subsequent visits follow Incident 2 rules as far as documentation, etc., except instead of having to be under direct supervision like what we see with Incident 2 billing, CCM can be administered under general supervision, which is nice because you relax the need to have that physician or MPP under the same roof. Patients are subject to Medicare's 20% co-insurance, and that typically amounts to about $8 per month for most CCM. All right, so let's look at what's required as far as services to be able to bill a CCM code. So for traditional CCM patients, it's a bundled reimbursement per month, and in that month, you must have 20 minutes or more of clinical staff time. So this does not include time preparing to deal with a patient or documentation time. This is 20 minutes of time coordinating, talking to patients over the phone or however you might correspond with patients. For, Medicare then also has a category for complex chronic disease management or complex CCM, and that would be for patients that require 60 minutes or more of clinical staff time per month. And again, this all needs to be documented. For complex CCM, this would require moderate or high complexity medical decision making. And the one kind of tricky thing here is that the referring physician or MPP must be involved in the patient's care during the month that the CCM code is billed. So if the patient is not seen by the referring physician, or that referring physician or MPP is not involved in the patient's care, a complex CCM code cannot be billed. If for your complex patient requires more than 60 minutes, you can build an add-on, or you can bill an add-on code for our complex CCM patients, and that would be for each documented additional 30 minutes of clinical staff time, again, requiring moderate or complex medical decision making. As far as reimbursement, as I mentioned earlier, these are bundled reimbursements. So the reimbursement is meant to pay for everybody involved in the care of that patient for that month. And for your standard CCM, code. Again, that's 20 minutes of time, of clinical staff time. The code is 99490, and that reimburses a little over $40 per month. For our complex patients, it's a 99487, and that reimburses about $91 per month. And then again, for each 30 minutes additional, you can bill a 99489, and that's an additional $45 per 30-day bundled reimbursement period. Next is transitional care management. So transitional care management, or TCM, is essentially what it sounds like. It is meant to keep people out of the hospital once they've been admitted. Again, we're focusing here on Medicare patients. So this is something that was created by Medicare, again, with the goal of keeping people out of the hospital, reducing those 30-day readmission rates. What's involved in a TCM visit? Well, there are definitely different requirements that must be met. First off, somebody must communicate, some clinical staff must communicate with the patient or with the caregiver within 2 business days of discharge. That could be by direct contact. More commonly, it's done either via telephone or by electronic communication. There are some rules that say if you try, multiple times and you can't contact the patient within the 2 days, you have a little bit of a leeway, but they're pretty strict with that 2-day contact. In addition to that, the physician must have a face-to-face visit within 7 to 14 days of discharge, and that timing depends on the complexity of the patient. And medical decision-making of at least moderate complexity must be required. The nice thing about TCM billing is that multiple people can be involved with the care to the patient. The reimbursement does come as one bundled payment, one bundled billing code, and that encompasses all of the face-to-face interactions as well as any non-face-to-face telephonic, electronic activities that might be done for the patients. So as I mentioned previously, that face-to-face visit at either 7 days or within 14 days, that visit must be conducted by a Medicare Part B recognized provider, so a physician or an MPP. But they don't need to be the only provider involved in that visit. So you could have a pharmacist involved in that face-to-face visit, and they would be, just part of that bundled payment. So, for example, you might have the physician see the patient, but then the pharmacist do all of the medication reconciliation or the education, or your institution could involve the pharmacist however they thought was most helpful. But a physician must be involved in that visit. However, all of the non-face-to-face activities can be done by any licensed clinical staff, and that does include a pharmacist. So, all of these visit or activities follow Incident 2 rules, except that they can be done under general supervision as opposed to direct supervision. So again, that physician for all of the non-face-to-face activities does not have to be under the same roof. So as an example, in our institution, we have a nurse that makes that initial contact with the patient within that 48 hours, and then we have pharmacists that are involved in some of the other components of the TCM visits. One sticky point with TCM is because the whole idea of a TCM visit is to keep patients out of the hospital, you cannot bill for a TCM visit until the 30th day post-discharge. So not the date of the clinic visit or any of the other activities. You submit the billing after the 30th day post-discharge as long as your patient has not been readmitted. And they could be readmitted for any indication. It doesn't have to be the initial reason that they were in the first time, and that would void the TCM code. If that does happen, the TCM code converts to an E&M code for the face-to-face visit that the physician led, and all of those non-face-to-face activities just aren't reimbursed. TCM billing is a nice reimbursement. We have two different categories or levels of TCM billing for our high complexity patients, and you could equate that to an E&M visit billed at 99215. So our most complex patients, that TCM code is a 99496. For those complex patients or high complexity patients, they do need to be seen for that face-to-face visit within 7 days of discharge. And then again, that claim date, as I mentioned, is at the 30-day mark post-discharge. And you can see that that bundled reimbursement, again, encompassing both the face-to-face visit as well as any other services provided, reimburses at $226 and some odd change. So you can compare that to an E&M 99215 visit, which reimbursed at $141. So you can see you make a decent amount of money, more money, billing the TCM code. For our moderate complexity patients, so that would be equivalent to an E&M code of 99214, we would bill a TCM code of 99495. Those patients need to be seen for that face-to-face visit within 14 days of discharge. Again, that bundled code is sent for reimbursement after 30 days without being readmitted to the hospital. And that bundled reimbursement is $160. And if you compare that to the E&M level 4 or 99214 visit, that reimbursed at about $105. So again, you're making a decent amount more with that bundled TCM billing. Last but not least, we'll briefly touch on diabetes self-management training, or DSMT. So diabetes self-management training is meant to be a collaborative process to help people obtain knowledge and better self-manage their diabetes and those related complications. It's a Medicare benefit. It covers up to 10 hours of education within a 12-month time frame. You can divide that up numerous ways. 1 hour, the first hour essentially, could be either given as a group training or it could be an individual assessment. And then after that initial hour, you can have up to 9 hours more that has to be done in a group education setting. After that first 12-month period, you can continue to reinforce education with your patients and get reimbursed for up to 2 hours of additional education each year thereafter. The tricky point with DSMT is that either the provider who is providing the service or the entity, in other words, the clinic or the institution, must have a DSMT accreditation status. That accreditation status is offered by the American Diabetes Association's Education Recognition Program or by the American Association of Diabetes Educators Diabetes Education Accreditation Program. So either one of those two organizations have an accreditation process. And I did briefly look at the accreditation process or application, and you definitely have to meet with a whole list of different standards and goals and everything to go through that accreditation process. So it is somewhat of a task to go through it, but once you have it, either the provider again or the entity, then you can go ahead and bill via DSMT. Again, this is meant for Medicare patients, so patients must qualify for Medicare Part B, and like all those other Medicare services, with the exception of the MAW visits, patients are subject to a 20% coinsurance for these visits. You do not have to be a physician or an MPP to provide the service. You just have to carry that DSMT accreditation status. However, the physician or MPP must provide a written referral to the program for the patients. As far as what is reimbursed or how these are reimbursed, there are two different G codes that you can use. One is meant for individual training. So again, that first initial hour that could be given as an individual appointment. It's reimbursed in 30-minute increments, and each of those 30-minute increments reimburses at $52. And again, you can use up to 2 of those because you have up to an hour per year. Then the G0109 is meant for the group training, which is everything else. So again, reimbursed in 30-minute increments, reimburses about $14 per 30 minutes, and you have up to 9 additional hours of that group training that you could provide. So it's an additional 18 units. So that was a lot to go through in a short amount of time, and we went through a lot of different ways to bill. I wanted to provide a summary of everything we just talked to. So here you can see a description of each of the different 6 types of billing that we discussed, along with the codes that you would use to bill for those services, what they reimburse in the state of Wisconsin in the year 2018, and then what I thought were some of the most important takeaways from each of those different visit types. Okay, and that brings us to our learning assessment question. So I will read this and then we'll go through each of the different answers. So your institution would like to set up a pharmacist-managed service for patients with chronic diseases. You're debating between using CCM, Incident 2, or facility fee codes. So let's look at the various 4 scenarios and figure out which option makes the most sense. So scenario A is use CCM as your anticipated patient population is 10% Medicare, 30% self-pay, and 60% private insurances. In scenario B, we have the recommendation to use Incident 2 billing as you are in a hospital-based clinic with a physician who will be able to provide direct supervision. Scenario C is use CCM as you are in a hospital-based clinic and anticipate much of your patient interaction will be face-to-face. Or scenario D, use facility fee billing as you are in a hospital-based clinic with a physician who will be able to provide direct supervision. Okay, so let's look at scenario A. So scenario A would not be the most viable option because for CCM patients, CCM, remember, is meant to be only for Medicare patients. So if your population's only 10% Medicare, this probably isn't a very viable way to support your service. In scenario B, using Incident 2 billing, okay, so you're in a hospital-based clinic, which is good because you can use Incident 2 billing in either a hospital-based clinic or a physician-based clinic. And you're going to be working with a physician who would be able to provide direct supervision. So this makes sense. You could do this. However, if you remember back to the reimbursement rates, the restrictions for pharmacists right now is restricted to a 99211 for an Incident 2, and that only reimburses about $20. This would be the only way, one of the only ways that you could bill if you were located in a physician-based clinic. However, given the fact that you're located in a hospital-based clinic, you have other options that become available, such as facility fee billing, and that reimburses at a much, much higher rate. And this is actually the way that we support our services at Monroe Clinic. We bill facility fee as we are in a hospital-based clinic. So it's a much more financially viable way to support your services. Scenario C, use CCM as you're in a hospital-based clinic and anticipate much of your patient interaction will be face-to-face. Okay, well, here's similar to situation B. You are in a hospital-based clinic, which is good. However, you're going to be interacting with patients face-to-face. So using the CCM coding is not the most financially viable way because you could bill facility fee and get reimbursed a lot more for all of your patient interactions. So that brings us to scenario D, which is to use facility fee billing as you're in a hospital-based clinic with a physician who will be able to provide direct supervision. So of course, this is the correct answer. We are in a hospital-based clinic, so we are able to bill facility fee, and we do have that physician who's going to be able to provide the direct supervision for us. So everything comes together for scenario D, and that is the most viable option. All right, well, that brings us to the end of the webinar. I wanted to include my contact information, so by all means, if you've listened to this and you have some questions, I don't profess to have all of the answers, but I definitely have experience with various different billing methods, and I would be more than happy to talk to any of you. Thank you very much.